Hi, my name is Holly Yeagley, and I am a DNP student at Maryville University, and today I'd like to talk with you about my scholarly project. The committee members for my project include Dr. Maria Snell, who was my chair and also my second reader for this course. And my community members include Major William Clark, who is a child and adolescent psychiatrist, and Major William Crosby, who is a doctor of nursing practice and a pediatric nurse practitioner in the clinic where I completed my data collection. Some terms I'd like to go over before we get started is one, TRM I'll be using for traditional referral model, IMHM integrated mental health model I'll be using throughout, CAP for child and adolescent psychiatrist, PPCP for pediatric primary care provider, and MTF for military treatment facility. Some background to this project. It is no surprise or unknown knowledge to anyone that we are in the midst of a mental health crisis. Suicide is currently the third leading cause of death between ages 10 to 24 years, and children as young as 5 have gone on to actually commit suicide. The number of mental health providers is not sufficient to handle the demand, which is ever increasing. Primary care providers are currently needing to treat more mental health needs within their clinic, and integrated mental health models are an option that have been brought into the forefront over the last 10 to 15 years to try and combat this lack of child and adolescent psychiatrists and other mental health providers. The integrated mental health model at the facility I did my research at began in 2015 under the direction of Dr. Susie Nelson. From 2015 to April of 2022, this was the primary model utilized for primary care providers to initiate referrals to mental health and CAP providers within the mental health clinic. In April 2022, unfortunately due to staffing limitations, the integrated mental health model did have to be discontinued. And in May of 2022, they began utilizing the traditional referral model as the sole model. So the aims of my my scholarly project include to compare the speed at which care initiation from primary care provider to child and adolescent psychiatrist, to compare the difference between the two, and also to identify which method of care delivery allows the most expedient care by a child and adolescent psychiatrist. The PICO question that guided my project is that of in pediatric patients seen in the primary care clinic from 6 years to less than 18 years, does the integrated mental health care model compared with the traditional referral model affect the time from recognition to initial assessment by a child and adolescent psychiatrist over 2 separate 4-month timeframes in which each model was the primary method utilized? The literature review I completed on this was primarily focused on integrated mental health models. The themes that I was able to pull from the literature included barriers to mental health care, and those included things such as stigma, lack of comfort with primary care providers, lack of mental health providers, and also the lack of follow-through. Regional needs were also a theme in that it's not a one-size-fits-all, so I can't say this is how integrated mental health models will work, and they would work everywhere. That wouldn't be correct. And then cost. It costs more to initiate an integrated mental health model, though the literature does show that in the long run, at 12 months out in some studies, that the cost was actually less. And then methods of integration are variable, which made it a little bit more difficult to study, and so there's a lot of information out there, but they're not all in one specific method. The benefits to integrated mental health models include that there is ample primary care visits. So when those integrated mental health models are combined with pediatric primary care, there is a lot of primary care visits. There's less stigma within the primary care setting, and there's less missed visits because those visits are made similar to they're well child care, and so they're not at a different facility, they're not more difficult to make, so there is less missed visits. So the goal of all throughout the literature of an integrated mental health model is to share expertise between child and adolescent psychiatrists, primary care providers, decrease the mental health burden on our children, and lessen the effects of having less mental health providers. The theoretical framework that I used through this process was the Donabedian method. The Donabedian method was created by Avedis Donabedian, and it involves 3 dimensions. One, the structural dimension, which includes your resources. So that's your amount of people, it's your space, it's your money to accomplish what you need to accomplish. And when we have problems in this area, then we tend to have access problems. The second dimension is the process, which is this is your patient and provider interaction. So this is how knowledgeable your provider is, how forthcoming maybe your patient is, but really this is all on the facility side of things. And so if you have a provider that has missing diagnosis or is uneducated in a certain area, then that process dimension is affected. And then the third dimension is your outcome. So that is the culmination of they got in to be seen, the provider saw them, and what was your outcome. And so these are all interrelated, and so one affects the other and vice versa. And it makes it a little more complicated sometimes when you're looking at the quality of care that you're delivering. One quote that I really enjoyed by Avedis Donabedian included was this: ultimately, the secret of quality is love. You have your patient, you love your patient, you love your profession, and you love your God. If you have love, then you can work backward to monitor and improve the system. So I think when we start with quality, when we start with our structures and our process and our outcome, we work backwards and we can fix the system in which those are working through. So the methods and design of my project include, one, I had to start off by getting approval. So I started with approval from the pediatric clinic leadership. I then moved on to IRB approval through Maryville University. And then once that approval was obtained, then I got my approval through the Defense Health Agency and the Human Research Protection Official at the military treatment facility. I also completed my city training, as did my chair. This was a quantitative exploratory design with a retrospective chart review. The dates of interest included December 1st, 2021 to March 31st of 2022 for the integrated mental health model. And then for the traditional referral model, those dates were May 1st of 2022 to August 31st of 2022. The setting for this project was a Midwest pediatric clinic at a large military treatment facility. The pediatric beneficiaries served there is approximately 8.2 thousand. The data collection for this project included primarily an initial CAP evaluation that was with the billing code of 90792, and it also needed a primary care provider referral to a child and adolescent psychiatrist or an electronic medical record documentation of a recommendation to a child and adolescent psychiatrist. Those were the 3 main data that were collected. The inclusion criteria for these participants included males and females of all ethnicities. They needed to be enrolled in the MTF pediatric clinic. The initial CAP evaluation with referral either in the electronic medical record with a referral or electronic medical record recommendation. And they needed to be age 6 to less than 18 years of age at the time of CAP evaluation. The exclusion criteria include those that were not enrolled to the MTF, those that were missing either a CAP evaluation or a starting point of their recommendation or referral, and those that were not within the age range, so those less than 6 and those that were over 18 years of age at the time of evaluation. The steps to the process included One, there was no participant engagement, and this was just purely data that was looked into. All approvals were in place, my IRB, MTF, etc., that we previously discussed. I was granted access by the clinic and hospital leadership to look at the electronic medical record for the purposes of this research. And then the data was provided to me via electronic spreadsheets. I vetted all of the data against the inclusion and exclusion criteria. Each chart was then assigned a number and placed onto a spreadsheet with the data that was collected. And then once it was de-identified, the data was sent to Dr. Paul's with Maryville for assistance in statistical analysis. The validity and reliability was increased throughout this project because we did 100% of the records during the time frame. So we didn't only do 10% of the records during the 4 months. We did all the records, and anyone that had a 90792, and then it worked backwards from that. The data was also consistent between the two groups. It was the same. It was the same data pool, so there was it was consistent, and then consistent inclusion and exclusion criteria were maintained. Ethical considerations were the data protection. All of the data remained protected throughout. It was on a double password protected computer. There were no conflicts of interest between myself and the patients or participants, and there was no participant engagement. The variables for this project included in the independent variables was the traditional referral model and the integrated mental health model. The dependent variable included the number of days from initial recommendation to the CAP evaluation that took place. The data for the traditional referral model was normal in its distribution, but the integrated mental health model data was not normally distributed, so we ended up using the Mann-Whitney U-test versus the independent samples t-test. This meant that we were going to be comparing the medians between the groups versus the means. The data analysis included, we had 61 total participants that were part of our, that met inclusion criteria. This was short of the power analysis completed by Dr. Pauls earlier in the year. That recommendation was initially 102 participants, so we were shy of that. The age of the participants included a mean age of 14 for the traditional referral model and a minimum age of 8, and then a median of 13. The integrated mental health model participants had a mean age of 12.33 years, a median of 11 years, and a minimum of 6 years. The data revealed a statistically significant increase in the number of days it took to establish care, initial CAP care. The traditional referral model took a median of 46.5 days versus the integrated mental health model, which took 23 days. That was a p-value of 0.17, making that statistically significant. There was a small to moderate effect size with an R value of 0.3. The results, some facilitators throughout this project were the knowledge and willingness of the data collection team. They were wonderful, and they were very good at being able to accomplish the data pull within the parameters that were set. This is also a learning platform, the facility is, and so they're used to doing evidence-based projects, and so that also definitely facilitated this project. Some unintended consequences that came, there were nothing related to the data pool, but the finding of increased wait times with the traditional referral model was an unintended consequence of the integrated mental health model needing to close due to staffing limitations. And then another unintended consequence that kind of was found during this was that once the integrated mental health model was discontinued, the pediatric staff were no longer able to facilitate appointments. So prior to, like, they could book appointments into the integrated mental health model. They could, their nurses could, as well as their front desk staff. But once the integrated mental health model dispersed, then everything turned into referrals. So just everything like took longer, which is consistent with what we have found. Some limitations of the project included the referral data could only be pulled up to 12 months in the past. So that limited the amount of data that we could gather. And then also the time frame that we collected data was, for the traditional referral model, was from May to August, which is a huge PCS time for the military. So there was less child and adolescent psychiatrists, and there was already few of them, so there were even less. And then same thing with pediatric primary care providers. There's a lot of movement of providers coming to the facility and leaving. So the amount of referrals that were generated during that time was likely less. And then the amount of child and adolescent psychiatrists during that time was also less, so less to receive. So there is a bit of an assumption that had there been more providers available on both sides, that there may have been a larger sample size for the traditional referral model group. Next is generalizability. So this project is very specific to this clinic and the way that it is functioning currently. So it's not generalizable to any pediatric clinic that happens to have mental health providers within their facility. I think that these results cannot be generalizable to other facilities. So some discussion. The project identified as it met its aim, and it identified that the median wait time for patients was increased by 50%, with 23 days for the integrated mental health model and 46.5 for the traditional referral model. The mean shows similar data, so it was up 34% with a mean of 38 days, and the traditional referral model's mean was 58 days. And the current research is supportive of this as well. It shows that integrated mental health models have generally less wait time than referral models. What are the implications? So I think the implications of this is that we need to continue to move forward. We need to continue to address the mental health provider shortages. We need to look into alternative integration methods. So one would be the Child Psychiatry Access Program. So that could be utilized as basically your phone a friend. You have a child you see, you call the Child Psychiatry Access Program and you discuss that patient. And they offer recommendations on a plan of care. Some telehealth options that are not specific for only child and adolescent psychiatrists, but do include them, are like Telemind and Doctors on Demand. Those ones offer still referral out kind of things, but they do offer shorter wait times than what you're seeing in the general public right now. And then we definitely have to continue training. So we need to continue to increase our child and adolescent psychiatry residency options, increase training for nurse practitioner, physician assistant education, and continue to incorporate mental health into pediatric residencies as well. Continue training. Each of us needs to continue pushing and learning more to help our patients, so online training and certifications. Continuing on with implications, so we need to continue to do research. We need to look at different implementation methods for integrated mental health models. We also need to look at appointment length, because the expectations and wants from all of us providers is that we want to help our patients, but appointment lengths are a huge limitation in primary care, as is cost. What it costs for a primary care provider to see a patient with mental health concerns is very different than that for a child and adolescent psychiatrist, as is the appointment length. So that does need to be addressed so that the care can be adequate. And then lastly, sustainability must be looked at. So it's a challenge in the military, and that for the same reason that we had the limitation of people moving, is that there's a lot of moving pieces and a lot of moving people in military medicine. But the caveat to that is that integrated mental health models are variable, and they can be implemented to possibly acknowledge that and be prepared for that as long as it is in the planning part. So my conclusions is we did have a change. The integrated mental health model seems to decrease wait times in comparison to the traditional referral model. So this increase in wait times is delaying care, though more research would need to be completed to find out if this is still meeting the standard of care. That's a difficult number to find out there, is what is the standard of care for wait times. The data does, for this project, does suggest that an integrated mental health model would be helpful, but the question is it sustainable? And then do we just need to re-implement and change different aspects of it? And that would be something for this facility to look into. And then the goal, as is the goal for any care that we provide, is we want it to be timely and effective. We want timely and effective mental health care for our patients so that we can save them the challenges of untreated mental health care in the future. I welcome any questions. You can please refer them to my school email address. I thank you so much for listening to my presentation, and I hope you have a wonderful day. Thank you. Here's the references. If you have any further questions, I can provide those to you as well.